Hi, everybody. Sorry about that. So this was a little presentation that I had put together again for the guys in the emergency department. Unfortunately, the emergency department is again quite busy this morning. So I'm just recording it and putting it out there. So hopefully you guys will benefit from it. It's just a little mini presentation. It's not going to take more than 10 minutes. And just to talk about rib injuries, specifically rib fractures, and what we need to look out for, and what the normal chest x-ray should look like. So it's really not going to take that much of time. I'm just going to teach you one or two tricks on how to look for rib injuries, specifically rib fractures. So I think this one here, it's quite easy. We've got a chest here where you can see, if you follow each of the ribs, which is what I suggest you always do whenever you've got any of these fractures. As you start to come down, you start to see the fractures. And I mean, even a cursory glance at it would have already shown you the amount of fractures that are present. So this is in multiple rib fractures. These are often quite dangerous, and they often present with the pneumothorax, as it does in this case. Now, in this case, the pneumothorax is easily visualized if you actually follow the lung markings. Now, we'll talk about what's going on here in a second, but if you follow the lung markings, you'll see they sort of stop at this rib level, rib 4, and they don't go above to 3, 2, and 1. So all of this is just empty space. And the problem with these types of rib fractures is that very often these are causing a tension pneumothorax. And in this case, it hasn't, but it can. One of the cardinal signs of a tension pneumothorax is that your trachea and your cardiac shadow start to shift away from the side that's injured. So in this case, it's more likely an open fracture that's taken. An open wound, so the air is able to escape, and that's why we don't see too much of a shift or any shift at all, actually. So the pneumothorax is something to watch out for as well. Now, these rib fractures, technically, these are flail sections because these ribs are not attached to the sternum. So technically, it is a flail chest and does need to be treated as such. And a flail chest is also quite dangerous, the reason being that the lungs are unable to ventilate properly. So as the patient is breathing in, that part of the lung is not being ventilated. And as the patient breathes out, because of the changes of pressure being the opposite way around, they don't often get air going into those sections, and they often get lung collapse, atelectasis, and those areas of the lungs are often quite badly damaged. And in fact, what we are seeing here, and the reason why it looks so whited out, is because this is actually a pulmonary contusion that's sitting underneath there. You could even argue that there might be some air under the diaphragm, so there could be injury to the abdomen as well. Although, of course, this could just be a bit of fluid or something else, but there is something going on over there also. The reason why I say it could be fluid is because you can see there is a little bit of a meniscus over here, even though there is one on this side as well. But this line here is just a bit worrying. But the main thing to look at are the ribs and these fractures that have taken place over here. So it's quite a serious injury. Now, the thing is with the ribs, and because of how they are shaped, I actually just want to see if I can draw this out for you. Sorry. I don't know if they've got the drawing thing on here. They do. Okay. So let me just try and get something here. Just try and get it nicely and in red. So the way your rib is shaped, your rib is shaped like that. Apologies for the shakiness. So, if you've got your posterior end over there and you've got your anterior end over here, and because it's in a C shape, the most likely place for fractures to occur is in this area here. All right. Now, that's especially with force that's coming in from the front or from the back and from the side. Because of the way the rib bends, it tends to fracture around here. However, if you have severe force coming from the rear, you can, of course, fracture your ribs anyway in this posterior section, and also with the anterior section as well. Again, sorry for the shaky handwriting. I'm using a trackpad. So really, you can have fractures at any point, but the most common is anywhere along the curve. And if you have ever eaten ribs, you'll know that it's quite a strong bone. I mean, it's not a weak bone at all. And it takes quite a bit of force to be able to fracture the ribs. So what you normally see is that these are considered high impact injuries, high velocity injuries that normally cause. Now, single rib fractures, of course, or hairline fractures can occur with minimal force, but those like what we are seeing here, these are, of course, quite high impact injuries. So lung contusions are quite common. Cardiac injuries are quite common. Mediastinal injuries can occur. But the most common injury, of course, is lung injury. You can get liver injuries with, spikes going into the liver, the stomach as well. So it's not unheard of for those things to happen. But by far and away, the most common is a pneumothorax. And you can, of course, have a tension pneumothorax as well. So with the tension pneumothorax, of course, the problem that's occurring is that the air that's surrounding now that lung and causing compression is actually causing compression of your heart, and your heart is now unable to expand. And if we know Starling's law, your heart needs to expand to be able to contract. And because it's unable to expand, it's unable to contract. And it's a vicious cycle, because the less it expands, or the less blood that it takes in, the less blood it pushes out. So the next time it's got even less blood, which means it pushes out even less, which means it gets back even less. So it's a vicious cycle, and a death spiral that eventually causes the patient to die as well. So these are just some of the things that we need to watch out for when we are looking at fractures. Now, this is just a little trick that I like to use. I just want to hide this. There we go. And the floating meeting controls. Okay. So what I like to do is, when I'm not 100% sure of whether there are fractures or not, I like to turn the X-ray on its side and then actually just follow this line that's made by the ribs themselves, right? So where the ribs are curving, you'll see they make a nice continuous line. It's not necessarily absolutely smooth, but it generally tends to be continuous. So when you see that 90% of the time or 99% of the time, everything is okay. And when you turn it onto the side where we can see the fractures, you'll start to notice that there's a bit of discontinuity. You start noticing that there's incongruence of the line. And then sometimes you can actually have the ribs being pulled in, if there's severe fracturing. And then you have this, loss of continuity of the line. So this is a little trick that can help you sometimes. It's not foolproof. It's not to say that if you see a continuous line, everything is 100% okay. But if you don't see a continuous line, then it gives you an idea of, listen, there may be something going on this side. So what I would suggest is practice. Now, I mean, not all X-rays are as obvious as this one. So that's why I say it's just a little trick to help you to be able to pick out fractures if you can't see them. Or if you suspect that they may be there, but you may not be looking at them. Of course, you can always ask for oblique views. If you suspect it's more posterior, or you're struggling to see it, or you suspect it clinically. I don't have an oblique view on this, but it gives you a good picture of it as well. So, yeah. So in this one, what we see is surgical emphysema. Now we can, again, if we look at the ribs, we can actually see all these fractures that are taking place around here. So it's quite a severe fracture that's taken place with almost complete collapse. Well, it's difficult with the tension. Let me just say, with surgical emphysema, it's very difficult because it obscures quite a bit on the X-ray. But in this case, the lung is just about there from what I can see. But all of the streaking that you see underneath is, of course, air that's collecting in the subcutaneous tissue. For those of you who've never felt surgical emphysema is basically like dry, crunchy leaves. So if you've ever in autumn stepped on a crunchy leaf, held a crunchy leaf, dry leaf in your hand, that crunch that it makes, that's exactly what this feels like. So what we have is that we have a pneumothorax. The pneumothorax in this case is more of a tension pneumothorax, because we can actually see the trachea being deviated. We can see the cardiac shallow being pushed. And we can see all of this air that's actually collecting underneath this. This is an extreme example, but it is something that can occur. But even mild streaking, oops, sorry about that. So even mild streaking, air streaking in the tissue planes, if you see gas in the tissue planes, it should alert you to the fact that it could well be pneumothorax, okay, as well as rib fractures, okay. Now, in these cases, patients are doing intercostal drainage. I've seen patients like this where this is most likely a main bronchus, or one of the main large airways that's been involved, have 2 to 3 IC drains to be able to actually remove the air as it's coming in. Very often the patients need to go to cardiothoracic surgery quite urgently. You can also have other associated injuries. I mean, if there's something that's this bad, you've got to look around the rest of the x-ray. Are there other fractures? Is there a possibility of, any sort of mediastinal injuries, tracheal injuries? These can all be part of it as well. So these are the things that you look for when you look at these x-rays. Now, these are just some pictures just to show you more or less what you see on an x-ray. And the first thing I wanted to point out, is that how you count the ribs so that you know which one is which. Some people do get a bit lost when it comes to that. So just remember, above the clavicle is normally the first, and then you come down to the second, third, fourth, fifth. And remember that this, what we are looking at, is the posterior rib, and that the anterior rib actually folds around. So the anterior ribs are a bit harder to see on a normal x-ray. You normally have to ask for an oblique view to be able to see the anterior rib, and a sternal view if you suspect a sternal injury or sternal fractures between the sternum and the ribs and things like that. Now what I'm going to do for these two is that I'm actually going to put it on the group as well, so that you can either take a screenshot of it here. Let me just hide this here. So you can either take a screenshot of this here now if you want, and keep it on your device, or alternatively, I am going to put it up on the group so that you can just keep it on your phone for you to be able to see. So these give you all the major landmarks that are present on a normal chest x-ray. And like I said, we're just looking, it's just a short presentation just on rib injuries. So I hope you guys enjoyed it, and hopefully we'll try and do a resuscitation scenario tomorrow to talk about a patient who's quite severely injured and what can go wrong and how we try and resuscitate this patient. So thanks a lot. Hope you'll enjoyed that. And yeah, we'll try and have another one tomorrow. Keep well. Bye.